It is me again, Dr. Jenkins. Here we go. So we just finished the hip and pelvis. So we're going to move on down the lower extremity and talk about the knee. I think this is kind of a more fun chapter for a lot of people because it's much more relatable, I think. So I hope that's the case for you. Okay, as always, we're going to be following along with the notes. So if you can read about the characteristics, you can see it is the largest and most complex joint of the body. You may think that sounds a little funny because, wouldn't the hip be larger? But when you incorporate all parts of the knee, it is the knee. Because not only do we have the actual knee joint, which is the tibiofemoral joint, we're also going to have that patellofemoral joint. And the joint capsule, folks, goes around both. So when it's all said and done, this does tend to be the largest joint. And it is the most complex, which also might be surprising because you think about the shoulder, that can allow for a lot of complex movements, but the joint structure wasn't as complex. The ball on the socket allows it to give us that much motion pretty simply. But here, there's a deceiving amount of things going on. So it is quite complex. Okay, so if we go back, because I always like to review, I know, we talked about the shoulder. What gives the shoulder its majority of stability? The muscles. We talked about the hip. What gives the hip the majority of its strength and structure? Bony congruency. This is all a review. These would be great things, by the way, once we get closer to the final exam, which is multiple choice. But it should come as no surprise that I could be asking you about what provides the majority of stability to all of the main joints that we've discussed. And then we talked about the elbow. And that was kind of fun because it was about 50% bony congruency and about 50% ligaments. So we've really kind of seen a lot of variability. With the knee, as you can see, the knee gets most of its stability, not in this case from RG3, but because this is in the middle of the injury, but the knee gets most of its stability from ligaments. We have yet to see a joint that we get most of its stability from ligaments, so this will be new. But I would hazard to guess that all of you already know something about the knee ligaments, so it really should come as no surprise. We are responsible, we rely on the ligaments for most of our support. All right, so as usual, we're going to start by talking about the bony anatomy. And then there's quite a few other things related to that bony anatomy that we'll get into. So here we go. Roman numeral 2, we're going to start with the knee joint. So the actual knee joint, as your notes say, is a joint between the tibia and the femur. Therefore, it's called the tibiofemoral joint. We, however, are going to be more specific. So we'll start there. You should know that the knee joint is called the tibiofemoral joint. But let's be more specific and talk about the actual articulating surfaces. Let me just jump ahead for 1 minute. All right. So the articulating surfaces more specifically, on the tibia, we have slight depressions in the tibial plateau. So if you were to look at the top of that tibia, it's a little bit concave. So that's the articulating surface on the tibia. So we're going to say depressions in tibial plateau. Slightly concave. On the other side of things, we have the femoral condyles. A condyle, of course, is a rounded edge. So the convex femoral condyles fit into the concave depressions in the tibial plateau. So on the femur side of things, the articulating surfaces are the femoral condyles. They come down like two rounded convex bumps, and they fit pretty nicely into the tibial plateau. Certainly not a deep joint though, right? So it's not like a ball and socket. So these depressions in the tibial plateau are certainly not like a deep socket, but they're just concave enough. There's enough of a little depression to allow the femoral condyles to sit in them. All right. Now, if you wanted to get specific, we're not going to get that specific. We're not going to get that specific. But if you wanted to, it's actually two side-by-side joints, because in the middle, there's no articulation between the femur and the tibia. So if you wanted to be really specific, you would say it's two side-by-side condyloid joints. But we don't need to get that specific. So we're going to be a little bit more simplistic, and the type of joint is a modified hinge. So it's a synovial joint. More specifically, it is a modified hinge synovial joint. You may recall the true hinge joint that we talked about was the elbow, the humeral-ulnar joint. That is a true hinge joint, the elbow. It can only flex and extend, much like a door can only open or close on its hinges. Here we have a modified hinge because we can perform flexion and extension at the knee, but as we're going to find out shortly, we can also do a little bit of lateral movement. And that's what makes this a modified hinge joint. If you were to flex and extend your knee, it more or less looks like a hinge joint, kind of moves in one plane. But once we begin to look a little bit more closely at the articulating surfaces, there's a little bit of lateral movement. Not able to be seen with your naked eye, but it is still there. So that's why it's called a modified hinge joint. Okay, so I got some other pictures here for you to look at. Another good look here on our left at the depressions in the tibial plateaus. And then on the other end, we have the femoral condyles. That's how they fit together. We are going to talk all about the ligaments. This is a good little teaser to see all those ligaments that give this joint its support. And then, of course, outside the ligaments and outside of the joint capsule, we have the muscles. Another look, again, we can get some, this is probably the best look so far, at the slight depressions in the tibial plateaus, and then how that really perfectly rounded, for the most part, femoral condyle fits into it. All sorts of good pictures. Okay. So we're going to talk next about the screw home mechanism. And I'm going to stay on this picture here. So you can see it on your sheet there, screw home mechanism. I'm going to do my best to describe it on this video. I'm going to bring a model to lecture next time we meet, and I'll be able to show you this on the model as well. So have a listen. Hopefully you get the main points, and then you'll be better able to see it once we meet in person. Okay, so what is this screw home mechanism? So let me tell you what's happening, and then we can talk about why and the specifics. A screw home mechanism is a mechanism where right before full knee extension, So imagine, perhaps you're sitting down right now as you're listening to this and you're so focused. If you flex your knee, right? So if you have your knee flexed, Okay, that's the starting point, flexion. And then you go to straighten it or extend it. Well, as you extend and straighten it, right before it gets to the full straight position, this mechanism occurs. So right before full knee extension, the tibia laterally or externally rotates. The tibia externally rotates on the femur, and this, quote unquote, locks knee in place. All right, so right before full knee extension, the tibia is going to rotate laterally. So in this view of the knee, it's the posterior view. I'm going to give you a little quiz. Would this be a right or left knee? And we should be able to tell because of the location of the fibula. This just happens to be a right leg, right knee, femur, tibia, and fibula. So on this view, right before full knee extension, the tibia, the top of the tibia here, is going to rotate a little bit laterally. So imagine a slight twisting motion where the tibia rotates a little bit laterally or externally towards the lateral side. And this quote unquote locks the knee in place. You might be thinking, oh yeah, when I fully extend my knee, it kind of locks. And because sometimes if you stand, some people actually hyperextend a little bit and it can feel like that locking. This isn't that. That's just because of hyperextending. This happens right before you reach full extension, and you really don't even notice it. So screw hole mechanism, right before full knee extension, starting from a flexed position, right before you get your knee to be totally straight or extended, the tibia externally rotates on the femur, quote unquote, locking it in place. This relates directly to the closed pack position of the knee. The closed pack position is just shy of full extension. It's after the locking takes place, so it's after the screw home mechanism. I can write this down to be really clear. So it's after position the knee is locked, but literally right before full extension. And that should make sense too, because I think maybe, but when you're fully extended, it's not quite the strongest. So a lot of knee injuries happen when the foot is planted and fully extended. So there's this window here for the true closed pack position after the screw home mechanism has activated, but right before full extension. And that's one of the functions of this screw home mechanism. By that slight external rotation of the tibia, it gives us the most bone on bone. So by quote unquote locking this knee in place, it gives us the most bony congruency, allows for most bone on bone contact. All right. Pretty cool. I mean, I think so, but all right. So as we move on down the notes here, what movements are allowed? Well, we've already talked about it. So it's a modified hinge joint. So of course, we're going to have flexion and extension, just like a regular hinge joint. But the added part is that lateral movement, that little rotation of the screw home mechanism. There is some gliding motion When we talk about gliding motion, that's when we're going to talk about this muscle called the popliteus. It's a pretty cute muscle, I gotta say. So this is a small muscle underneath the calf musculature, the gastrocnemius and the soleus. We can see it here in red. Let me delete some of this, or erase it, excuse me. So first of all, you should just see here that this is the popliteus muscle. There it goes. The function of this popliteus muscle, it internally rotates. So its function is to internally rotate tibia to unlock. Apparently I can't spell at the same time as I'm talking. To unlock the screw home mechanism. So this is going to happen when you want to flex your knee. This would be considered a gliding movement. So the popliteus internally rotates the tibia, and that allows for, and this is actually written on your notes here, right? You can read it here. As we unlock the knee and allow for flexion, the femur glides forward. So that's really the gliding motion. Femur glides forward as the popliteus unlocks the knee to initiate flexion. Boom, there you go. I just gave it to you right there, right? What's the gliding motion at the knee? The femur glides forward right after the popliteus contracts to unlock the knee to initiate knee flexion. Feel free to rewind the video a little bit. Hear that again. It was a pretty good explanation. Ha. So remember, when we talked about the screw home mechanism, the tibia was rotating laterally. So what that means is, when the popliteus contracts to unlock this, it's going to pull the tibia this way. So this muscle gets shorter, and it pulls the muscle in an internal rotation way to quote-unquote unlock the knee. Gotta readjust my position here. All right. Okay, you can read about the knee range of motion. You don't need to know that. All right, so before we get to the ligaments, as you noticed, I have a couple more bony landmarks that I wanted to point out to you. So we can talk about it here. We'll be doing some of the palpations in lab to better familiarize ourselves with these. Looking at the list here, we've already talked about the femoral condyles, rounded edges at the bottom of the femur. If you wanted to be more specific, a condyle is a rounded edge of a bone at an articulation. So in order for it to be considered a condyle, it has to be a rounded edge at an articulation where it touches another bone. I'm not going to ask you that, that's just there. We also have some epicondyles, which are up here. You don't need to know them. So there's a femoral epicondyle. Epi means smaller rounded bump. You don't need to know those though. We're going to be more focused on the condyles at the bottom. There is an intercondylar notch. Here's another look at the medial epicondyles. Okay, the intercondylar notch is not labeled here, but we'll label it right here. The intercondylar notch is this notch right here. It's between the femoral condyles. It's a notch that leads to an open space. what we're going to find out is that the anterior cruciate ligament, the ACL, runs through that space. That's why the space is there, because you might think, well, wouldn't it make more sense to have the bottom of the femur be horizontal and have more bone there? I suppose in theory, but we wouldn't have room for the ACL to pass through. This intercondylar notch, and by the way, intercondylar, inter means between, so it's between the condyles. This intercondylar notch is a little bit narrower in females, even adjusted to differences in size in the bones. Most often it's narrower. This is one reason contributing to why females are much more likely to have an ACL tear versus a male. We have a popliteal fossa, which is on the back. I think now I can erase this. So from the posterior view, we're able to see the popliteal fossa, and I have labeled that here for you. It's a fossa or depression or opening in the back. The function of that is to give space for nerves, arteries, veins, and lymphatics. So basically, you have a big bundle of nerves that come down. So we got a bundle of arteries, we got a bundle of veins, we got a bundle of nerves. So that space there is to allow the nerves, arteries, veins, and lymphatics to pass through. I've already talked about the tibial plateaus. It's the top surface of the tibia, has depressions that allow for the femoral condyles to sit in it. I think I have to sneeze. Pardon me. Lastly, I want to point out the tibial tuberosity, and that is the front. I think I have to sneeze again. Hold on. Excuse me. The tibial tuberosity is the bump here on the front of the tibia, a little bit lower. You can feel this. We're going to feel it in lab quite easily. Perfect. That's going to be an attachment site of a really big muscle group known as the quadriceps. Okay. All right, so now we can start talking about the ligaments. That gets me excited. Maybe it does you. All right, I had to go grab a tissue, so I'm so sorry. Oh, there's a picture of the intercondylar notch. The space in between there to allow the ACL to pass through. Beautiful. All right, I apologize so much. Allergies. Okay. So let's talk about ligaments. We are going to spend quite some time talking about ligaments because, as you know, ligaments are going to provide most of the stability to the knee joint, the tibiofemoral joint. If you strip away the ligaments, it's not a very strong bony joint. Sure, we have those rounded femoral condyles fitting into a slightly concave tibial plateau. That's true. But there's nothing on the sides. So if you take away these ligaments that we see in this picture, you basically have two bony surfaces on top of each other, but there's nothing on the sides to hold them together. So we rely a lot on ligaments. Excuse me again. All right. Everyone's heard of the anterior cruciate ligament. Let's talk about it so you know the details. Anterior cruciate. Cruciate means to cross. And what we're going to see is in the center of the knee joint, the anterior cruciate and posterior cruciate form an X. Here's the anterior cruciate. Here's the posterior cruciate. Indeed, it forms an X. As the name suggests, the anterior cruciate is on the anterior side. We are going to be, more specific. The anterior cruciate ligament runs from the anterior medial tibia. So it's important that we know the direction of the X that it forms. It starts at the anterior medial edge It might look more towards the center, but it's a little bit more medial. This happens to be a left knee because we know the tibia is more medial, the medial lower leg bone, and the fibula is the lateral lower leg bone. So by identifying that, we know that the anterior cruciate ligament starts more, the anterior cruciate ligament starts more on the anterior medial tibia and runs back to the posterior lateral femur. Posterior lateral femur. Excuse me again. So make sure you know that direction. Anterior medial tibia, posterior lateral femur. If you were to memorize one, knowing that it forms an X and it goes in a diagonal, you would probably already know the other. Of course, all day I'm fine, then I start to record this and my nose starts to run like crazy. So what is the function? The function of a ligament. So the ligament runs from a bone to bone, helps to hold the bones together, but more specifically with the anterior cruciate ligament. It prevents excess anterior tibial translation. I will bring a model to lecture so you can see this. Basically, this prevents, if you think about the femur being on top of the tibia, as it is, this prevents the tibia from moving too far forward. Imagine this tibia moving right at you. So if we were going to have a three-dimensional, if the tibia was moving anterior, if the tibia moves anterior, which means the femur would relative to it move posterior, right? If this moves anterior, that moves back. That's going to pull this tight. Well, if you pull the tibia too far anteriorly, it could stretch that ACL so much that it could tear. This is going to withstand quite a lot of force, the anterior cruciate ligament. Prevents excessive anterior tibial translation. It also prevents hyperextension. We're going to focus on it worded this way. All right, so on the other side, we have the posterior cruciate ligament. Here's a view of the posterior complex. Let's see. Oh, this is cool, right? This actually shows the ACL and PCL quite well. All right. So now let's switch to talking about the posterior cruciate ligament. So now we're talking about the one on the back. So it's more posterior. It forms the opposite direction. So basically, if you memorize that the ACL goes from the anterior medial tibia to the posterior lateral femur, then you'll know that the posterior cruciate ligament just runs the opposite way. So if I memorize one, I already know the other. What are some things to point out about the posterior cruciate ligament? It's a little bit shorter than the ACL. It's the opposite direction, so it runs from the posterior tibia to the anterior femur. It's shorter, but it's stronger than the ACL. It's a little bit thicker. It has a couple bands to it. Shorter, but stronger. So instead of preventing excessive anterior tibial translation, the posterior cruciate ligament prevents excess posterior tibial translation. And again, when I bring in the model, it'll be easier to see this. But if I were to push the tibia back, it would make the PCL tight. So the ACL and PCL work together to prevent the femur and tibia from going too far forward and backwards on each other. The ACL preventing excessive anterior tibial translation, and the PCL preventing excessive posterior tibial translation. All right, good. Moving right along. I'm going to come back to this picture, but for now let's talk about the cruciate ligaments. And we've talked about some cruciate ligaments before with the elbow, so those terms should be familiar to you. Cruciate means on the side. So we have a collateral. Why am I saying cruciate? Let me say that again. I apologize. The cruciates were in the middle, anterior and posterior cruciate. The collateral ligaments are on the sides. Collateral means on the side. Just like the elbow, we have the ulnar collateral and radial collateral ligaments. Here, we have the fibular collateral. That's the same thing as the lateral collateral. And we have the tibial collateral, which is the same thing as the medial collateral ligament. I think it's more common to call them medial and lateral, but you wouldn't be wrong to call them tibial or fibular. What are some differences between them? So the medial collateral ligament is thicker. We'll see this even more on the model. The medial tends to blend into the joint capsule. Even though we don't see the joint capsule in this picture, we certainly can see that the MCL is closer to the joint. See how it hugs the joint? On the other hand, the lateral collateral ligament is overall thinner. It tends to be more rope-like, so it might be thinner, but it tends to be a little bit more. The MCL is thicker and kind of flat and broad, whereas the LCL is thinner, but it's more rope-like, it's more round. And it's a little bit more separate from the joint. Doesn't blend into the joint capsule. It's a little bit further away. Okay, what are the functions? So I'm going to skip ahead because the functions are right here. So the functions of the lateral collateral ligament. So here we have an anterior view of the knee. We're looking straight on. We get a good look at just the main four ligaments. If we have a varus force, we remember a varus force is a force from the inside. A force from the inside will stretch the outer ligament. You might get a bruise on the medial side, but in terms of ligament stretching and potentially tearing, the varus force from the inside, the medial, is going to stretch and potentially tear the lateral. So the function of the LCL is to prevent against excessive varus force. So you can see the collateral ligaments are our side-to-side stabilizers, which means that the MCL is going to be preventing against excessive valgus force from the outside. A force from the outside will stretch the medial. You can see I got a question there for you. Which collateral is more prone to injury? You probably already know it's the medial collateral, simply because it's much more common to have a valgus force. Talk much more about those later. We do have something called a transverse ligament. You don't need to know this. The transverse ligament actually connects the menisci Trying to find a good picture here, and I don't really have a good one. So there's actually a little ligament that kind of connects the medial and lateral meniscus called the transverse ligament, connects both sides of the menisci, but you don't need to know that. What I am going to point out, though, are some of the ligaments of the posterior ligament complex. So on the posterior side, of course, we have the posterior cruciate ligament, but there's also a smaller set of ligaments, and they're often referred to, so we had the PCL, and our second ligaments on the posterior side of the knee would be part of the posterior ligament complex. You might actually hear that someone has an injury to the posterior ligament complex. Separately, it's the oblique and arcuate popliteal ligaments. So here we can see the oblique popliteal ligament, and then we can see the arcuate popliteal ligament. You don't need to know them individually, but I just would like you to know that they exist. So here's what you need to know. We have the primary PCL, and then we have a couple smaller ligaments on the posterior side. They're going to be more about helping to prevent against hyperextension. There you go. And lastly, we have the patellar ligament or patellar tendon. If I go back, here's the patellar ligament or tendon. I call it the patellar tendon. Some people call it a ligament. Technically, you could say either one. This is the tendon from the quads. So the quads are up here, and then they form one common tendon which crosses the patella and attaches on the tibial tuberosity. So that patellar tendon, the whole thing, patellar tendon. Some people will call it a ligament because the large portion of it goes from bone to bone, from the patella to the tibial tuberosity. So you could say either one. All right, moving on, we lastly have the menisci. Here's a nice, beautiful x-ray view. Actually, you get a really good view here of the depressions in the tibial plateau. Isn't that lovely? We get a look at the intercondylar notch, allowing plenty of space in between the joint surfaces for the menisci and for the cruciate ligaments. From the lateral view, we get a great look at the femoral condyle as it fits into the depression on the tibial plateau. It's lovely. Here it is again. I love this picture because it shows you a lot of things. It shows you the femoral condyle, but it also shows you that articular cartilage, like a glove on the end there. It's wonderful. The free space in the middle that houses the cruciate ligaments, patella, the patellar tendon from the quads coming all the way down. Pretty cool. All right, we have the menisci. Haven't we seen in many joints before an added piece of cartilage? The labrum was an added piece of cartilage in the shoulder and the hip. Well, here we have the probably most commonly known added piece of cartilage. This is in addition to the hyaline cartilage that lines the end of the bones. We have these added pieces of fibrocartilage. They're like little pads. There's my cat saying hi. There's a lateral meniscus and a medial meniscus. They sit right in the tibial plateaus. Their function is shock absorption. Overall, their function is shock absorption. We have a lot of forces on the knee. Not a whole lot of, there's some bony congruency, but not a whole lot to dissipate the forces. You know, the hip doesn't need as big of a cartilage because it has more bony surface area to distribute the forces and the loads. The knee doesn't have as much bony surface area, so we got to put in some added cushioning. Okay, in terms of structure, so we know the function is shock absorption. I like this picture on the top right here. So we can see that the medial meniscus is more C-shaped. Let me erase my little transverse ligament. From this superior view, we can see the medial meniscus is a little bit more C-shaped, where the lateral meniscus is a little bit more O-shaped. Not quite an O, but almost. So the medial meniscus forms more of a C-shape. The lateral meniscus forms more of an O shape. Other things as an aside, the lateral meniscus is actually attached to the ACL. You don't have to know that, but we can see it in the picture. Here's the ACL. It's kind of attaches to the lateral meniscus. I said that the function was shock absorption to distribute loads. There's some other interesting things about the menisci. They overall have a pretty poor blood supply. Overall, the meniscus has a pretty poor blood supply. If you damage a part of the meniscus, it's unlikely to heal well, if at all. It used to be that if there was a little tear in the meniscus, let's say there was a tear here, we just go in there and do a meniscectomy. Well, not me, but a surgeon would. Go in there and just take it out. Take out a big chunk. But they've moved a little bit away from the meniscectomies because they've noticed that when you take that out, you run a much higher risk later of osteoarthritis. I believe if you still have a little tear, particularly on the outer edge, they might go take it out. If you have more of a tear in the inner portion, sometimes called a bucket handle tear, where there's a tear in the middle, or like there's a tear right here, and a bucket handle tear is when you have a little tear in a flap, comes up, and then your knee can get kind of locked in one position. If you were to have an injury more here or here, they would probably not do a meniscectomy. It's too hard to get to. They can try and do a meniscus repair, where they stitch it together, but again, the meniscus doesn't have a great blood supply. More specifically, I would like you to review this not so good drawing. So the part of the meniscus, so imagine here we have the medial meniscus. This is also the medial meniscus. It's kind of forming a C shape, isn't it? Medial meniscus. The outer third has the best blood supply. So what I've shaded in green, and I alluded to it over here, but if you have damage to the outer portion, your chances of healing are much better. That outer ridge is going to be the closest to blood supply and the best chance of healing. In the middle third, what I have in red here, it's got a poorer blood supply. The inner third has very little to no blood supply. So this can absolutely relate to healing. So you should know that the outer edge has the best blood supply, which is to say not great, but the best of what's available. The inner has the poorest, therefore least likely to heal. All right, we're going to keep on moving here. So we're going to talking about the joint capsule. The joint capsule is that dense irregular connective tissue, like thick saran wrap that covers the whole darn joint. What I want to point out is that the joint capsule covers both the tibiofemoral and patellofemoral. So it kind of goes like this if I was going to draw it. So that's a point that's listed on your sheet there that you should review. This is the largest joint capsule in the body. The joint capsule is pretty thin, it's pretty loose. That word lax or laxity refers to looseness. Let's talk about intracapsular versus extracapsular. I've even given you some more notes here. This is true of any joint, but with the knee, we tend to talk about it more because of those ligaments and injuries to them. So intracapsular, as the name suggests, just means that it's a structure that is inside the joint capsule. It should come as no surprise that the ACL and PCL and menisci are inside the joint capsule. Let me go back to another picture here, even if I just look at this picture. Wouldn't the ACL and PCL, they're right in the middle of the joint. Of course they're inside the joint capsule. And the menisci, they're also as part of the joint, inside the joint capsule. So the cruciate ligaments and both menisci are inside the joint. Here we're going to add some terms for you. There's a term called effusion. Effusion is swelling, but we got to be more specific. Effusion is swelling inside of the joint capsule. Maybe you've heard of edema. Edema is often defined as swelling in a soft tissue. And another way of saying that is not inside the joint capsule. So if you just get a bruise and you have swelling, that's edema. It's not inside a joint capsule, it's just in the soft tissue. But we can think about the knee. Maybe you've seen, or maybe it's been you. If someone tears their ACL, they're going to have a certain type of swelling. It's not going to look like edema, like a bruise in your quad. Effusion is swelling inside the joint capsule. For an ACL tear, you may be surprised. Someone has an ACL tear, and a lot of times there's a lot of swelling in the back of the knee joint. And the reason is because the ACL is inside the joint, when you have swelling, the swelling can move anywhere within that joint capsule. It's not going to necessarily be stuck only to the front of the knee. Because it's an open capsule inside there, the swelling can go anywhere inside the joint capsule. And it tends to settle into the back because of gravity. A lot of times someone tears their ACL, they're sitting or lying on the ground, and gravity tends to have it go towards the back of the knee. Okay. Extracapsular would refer to structures outside of the joint capsule. In the knee, we're talking about the collateral ligaments. Even though the MCL kind of blends in with the joint capsule, it is superficial to it. So these are extracapsular. And this means that if you have an injury to either one of these, your swelling is going to be localized. An MCL tear, they're going to have swelling on the medial aspect of the knee. It's not inside the joint. So make sure you review all of those. As a side note, if anybody has ever seen or has gotten your knee drained, sometimes we can get kind of stubborn intracapsular swelling, stubborn effusion, and that's when you would get your knee drained. You'd shove a needle in the joint to drain inside the joint. All right. Lastly, we have some bursae. Bursa is singular. We've had bursa in most of the joints we've covered. Remember, bursa is a fluid-filled sac to reduce friction. You don't need to know the specific ones. I've got a picture here. There's a suprapatellar, which is above the patella. There's a prepatellar, which is superficial, right on top of it. There's a deep infrapatellar underneath. There's all types, right? Okay. I do want to mention something else. It won't be on any tests, but it's here. There is a fat pad. We'll see another one of these when we get to the foot, because there's a fat pad under your calcaneus or heel. Here, a bursa is a fluid-filled sac. It's pretty thin. It turns out that we need more cushion from friction, so we actually have a little fat pad. Perfectly reasonable there for a reason. We mentioned the IT band in the hip portion. So here, we're going to review it again because it runs along the lateral thigh, but where does it insert? The IT band, let's look over here. The IT band comes down and it inserts on the lower leg, on the fibula, as a matter of fact, right? So it comes all the way down on the fibula, so it can absolutely lead to some knee pain. So even though we think of it mostly as a hip and thigh structure, because it comes down and inserts pretty low, actually past the knee, it can relate to some knee problems. Its function, I don't think I discussed this in the hip and thigh chapter. The IT band, its function is mostly as a stabilizer. Kind of helps to keep all those muscles in check, in their location where they belong, I should say. All right. We're going to keep on moving here because we've got to get to the patellofemoral joint. And I think I was supposed to have a picture on the other side here. It didn't show up here, but we'll just go with it. All right, so this is our second joint of the knee complex. The true knee joint was the tibiofemoral joint. We also have the patellofemoral joint, and it's a little interesting. So this joint is formed by, as the names suggest, the patella, kneecap, and the femur. What happens is, patellofemoral, this patella sits in a groove, and as we flex and extend at our knee, the patella slide, let's say it starts here, the patella can slide down in that groove. So if I were to outline, we could do something like that, rectangle. The patella slides up and down along that groove as we flex and extend the knee. The patella, to refresh your anatomy knowledge, is an example of a sesamoid bone. The patella is a sesamoid bone. This is a bone that's free floating, which means it's not directly contacting another bone. When you are in full extension, your patella is not touching the femur. So it is a sesamoid bone, free floating. But when we flex our knee, the patella will start to contact the femur. So you don't need to know all these examples of the angles, but this is helpful for us to point out a couple of things. So the underside of the patella is a convex surface. If you've ever picked up the patella when you were in anatomy, the patella fake bone, it's got a weird shape to it, right? And it shows here the underside is a little bit convex. It's kind of angled. It's a little convex. So the underside of the patella is convex, and it fits into a groove on the femur. Sometimes this is called the patellofemoral groove. Sometimes it's called the trochlear groove. Here I have it called the patellofemoral groove. But again, we have to have two matching bone surfaces. So the patella, the underside of it, is convex, but yet the patellofemoral groove in between the femoral condyles up here, this is more concave. So the specific articulating surfaces would be the underside of the patella fitting into the patellofemoral groove. The underside of the patella fitting into the patellofemoral groove of the femur. All right, let's make sure we get these things written down so you know that you need to know them. At full extension, let me erase that. At full extension, at full knee extension, there's no contact. No contact between patella and femur. In lab, we're going to be identifying things that show us this. So we're going to look at patellofemoral motion, and you're going to see that when the knee is fully extended, you can move the patella around because it's not contacting the femur. However, at about, and we say about because it changes for each person, at about 20 degrees of knee flexion, patella will contact femur. At about 20 degrees of flexion, and from there on, it will contact the femur. And by the way, that's what it's trying to show you in this picture. We can see here, 0 degrees knee flexion means full extension. Look, no contact, there's space. At about 20 degrees of knee flexion, we're going to get pretty close to touching. And then from then on, there's some touching between these joint surfaces. What type of joint is this? Technically, I just came here to get more space to write, folks. Technically, it is a plane or gliding joint. We really can't classify the motion as flexion or extension or adduction or abduction. Simply, the patella glides up and down in that patellofemoral groove. So if I come back here, the patella glides up and down. So the motion is a gliding up and down. There is a little bit of a tilt to the patella as well, and that's what this side is trying to show you. So not only is there gliding straight up and down in that patellofemoral groove, but there is a little bit of a tilt. So sometimes there's a little bit of tilting either way, but we're not going to worry about that. The primary movement is just it slides literally up and down in the groove of the patellofemoral groove of the femur. All right, we've got quite a few functions to list, and this might surprise you. And I've listed them out for you, right? Yes, I have. One function of the patella, these are all important, by the way. Some of them you think of, so let's start with the easier ones, actually. Look at letter C, protection of knee. I mean, come on, folks, the fact that you have that patella there, it protects the knee. If you get hit or some kind of trauma straight on, there's a bone there to protect you. It does increase area of contact between the patellar tendon and the femur. I'm not going to worry about that one as much. Let's focus on letters A and C. So C is it gives some protection. Just the fact of having that patella there gives you some protection. But another one is it increases the angle of pull of the quadriceps. And that's what this picture is trying to show you. You know, we talked about the quadriceps tendon. So remember, the quadriceps muscle group is up here. And also there's, let's say that's rectus femoris. Then there's a vastus lateralis. And then there's a vastus medialis and a vastus intermedius. Well, all of the quads form one tendon. And you might wonder, well, why on earth does that tendon go over the patella? Seems a little bit long and inefficient. And then it comes all the way down to attach on the tibial tuberosity. So it increases the length of that tendon, right? So a longer lever arm, one could argue. But more importantly, it changes the angle of pull. So one option would just be to have an angle of pull, and I know I say pull funny, it must be my mid-Atlantic accent. I mean P-U-L-L. It increases the angle of pull. One option, and this is how most muscles go, you have, let me get this in here. You have a muscle belly and you have a tendon on either end. That's the worst muscle I've ever drawn. You've got a muscle belly with a muscle tendon on either end. Usually, that muscle tendon attaches to a bony process right there. So in other words, the angle of pull is just like linear. The tendon is pulling on the bony attachment like that. But what's happening in the quads is we once again have all these muscle bellies. Then we have this attachment up top, the origin. We're looking at the insertion. So the quadriceps insertion tendon, it's not just short like this one is. It's longer, and then it goes over the patella, and then down here. So instead of it just being a direct linear angle of pull, this angle of pull goes over and then down. So we can see the difference. This is option 1, like most muscles. But look at this angle of pull, right? And that's what it's trying to show you here. The muscle tendon comes down. This acts as the patella. Then the muscle tendon goes all the way over the patella and then down. By increasing the angle of pull, it better directs all the quad muscles together. So one benefit of increasing the angle of pull is that it better directs all the quad tendons together. So we could actually take 4 individual muscles and form one tendon. So it better directs all those tendons together so we can really maximize the force from all those 4 muscles into one place. And by lengthening the tendon and increasing angle of pull, we basically have around 50% greater force production. I'm not going to ask you that number, 50%. But by increasing that angle of pull, it's like a pulley system. Can't you generate so much more force by utilizing a pulley? If you're trying to lift something, you can make a little pulley system, and isn't it much easier to lift something? So it allows you to generate more force. In that case, it's the force needed to lift something. In this case, it's the force that we can produce at the quads. So the quads are not only powerful because we've got 4 muscles, but it's made so much more powerful. Oh, my cat's making an appearance again. Oh, hi, Kima. She brought up, you wanted to say hi to the class. Okay. They want me to finish sooner, so you better stop distracting me. Sorry about that, folks. So it really allows the quads to produce all the more force, which is really cool. Okay. There's also a proximal tibiofibular joint, shown here, circled in red. Proximal tibiofibular, between the tibia and the fibula. This is not part of the knee complex. I just wanted to point out that it exists. We obviously need to have the fibula and the tibia be connected, but it doesn't contribute towards the overall, it's not part of the knee complex in that way. All right, folks, I want to do a quick review of the muscles, and then we'll be done with this video, and we'll be able to do the rest when we meet in person. We already introduced these last week in the lab for the hip and thigh. So that's why I can review them more quickly here. So we know on the anterior portion of the thigh, we have the quadriceps, rectus femoris, vastus medialis, vastus lateralis, vastus intermedius. Here's a weightlifting dude, bodybuilder dude. We can see, pretty cool, the vastus medialis, the rectus femoris, and vastus lateralis. That's pretty cool. We're going to talk about this more later in the PowerPoint, later in lecture, about the individual action of each of those muscles. But of course, collectively, they do leg extension at the knee. We know that they all attach at the tibial tuberosity. Things to review. We talked about the sartorius. We'll review in lab the functions of it. And we talked about the gracilis. So I told you that the gracilis, it's a hip adductor. And it reminds me of the seam of your pants because it's superficial and it runs straight up and down along your inner thigh. The posterior musculature, so I'm going to skip ahead until we get to, okay, here we go. So we're going to talk more about that. So many more things to talk about. I can't wait. We're going to talk about more of the quads. Here are the posterior muscles. We already know the posterior muscular muscles are the hamstrings. The lateral hamstring muscle is the biceps femoris. And then we have our two medial muscles, the semimembranosus and tendinosus. Semitendinosus is on the medial side, more on top, more superficial. And the semimembranosus is on the medial side, it is deeper. The overall action of the hamstrings would be to flex the leg at the knee. The quads do extension, the hamstrings do flexion. As an aside, some of these muscles can also assist with that tibial rotation, but you don't need to know that. I already mentioned the popliteus. The popliteus is the muscle that does internal rotation of the tibia to unlock, quote unquote, the knee joint. The popliteus can also assist with knee flexion, but certainly its primary motion is going to be the popliteus. Gastrocnemius and plantaris. So the gastrocnemius is your calf muscle. It will do ankle plantar flexion, which is kind of a calf raise. But it can also assist with knee flexion because it originates on the femur, comes all the way up here. I mentioned this before. Muscles have actions at the joints they cross. The gastrocnemius crosses the ankle, so it can move the ankle, but the gastrocnemius also crosses the knee, and it attaches on the femur. Therefore, it can assist with knee flexion. The soleus is the muscle underneath the gastroc. It does plantar flexion at the ankle, but it does not move the knee because it doesn't originate above the knee. Last muscle I want to introduce is a muscle called the plantaris. It's teeny tiny. People sometimes get the plantaris and the popliteus confused. The plantaris has a small muscle belly here, and its tendon goes all the way down. So it actually runs along with the gastroc and the soleus. The popliteus stays only up here, and it unlocks the knee joint. All right, we're going to end there. We will pick up the rest when I meet you in person.